Have you been diagnosed with cancer, or do you know someone who's been diagnosed with cancer? As I say, I'm sorry if you've received this diagnosis, but chances are many of the people that have heard the word cancer may not have the total truth about how the body heals and how the body responds with certain things that you give it. But here's the thing that happens. You hear the terminology alternative, and then you hear conventional. Like somehow, if you try something alternative, it's something less than. And when you try something con cons what's the word? Conventional. There we go. Conventional, that somehow that's better. Well, today we're going to be talking with someone that I fell in love with at one of the conference that I attended, the Annie Appleseed Project Conference and Best Answers for Cancer. I was very impressed with how he spoke, what he had to say, and it's Dr. Sean T. Devlin. He is a DO. He is a holistic medical doctor, and he is integrative medicine and integrative oncology. I'm sure that he has this journey that took him from allopathically trained to where we are today. And I am excited that he's going to be joining us.
And when you need a friend, you can count on me. I'll be right here waiting for you.
Hi, my name is Lillian McDermott, and I am a certified life coach and the host of the Lillian McDermott radio show, Classroom. If this is your first time tuning into the Classroom, please know I've been waiting for you. This is a safe place where you can go when you need a friend. It is my commitment to provide natural ways to heal, and it is my mission to make awareness, responsibility, and truth a part of our everyday life. And I hope you, my listening, as well as my viewing friend, will feel empowered to embrace a new truth and live the life of your dreams. As I said, I met Dr. Devlin back in at the conferences, the back-to-back conferences I've been bragging about since I came back. And I was truly impressed that where oncology is going, where people's awareness of how the body heals is going towards. And since it is our sole purpose in life to give and receive love and knowledge, I am grateful that Dr. Devlin is here to do just that. Welcome, Dr. Devlin, to the Classroom. I really appreciate you being here.
Thank you so much, Lily, for having me.
Yes, absolutely. Well, okay, so you're classically trained, but
Yeah.
yet you have a different perspective about healing the body. So I would love to learn more about what led you down the path to become a doctor of osteopathy. Is that how it's
Yep.
it's a DO,
Yep.
and then have holistic behind it, MD, and then have a integrative and a different approach. So I'd love to share if you could spend some time sharing a little bit about your background and what led you to bringing the two worlds together.
Yeah. I mean, thank you for asking the question. A lot of people never chat with their physicians about, hey, how did you end up here in the seat in front of me? But it is a good place to start. I was originally interested in becoming a teacher and a researcher, so I wasn't really bent on doing medicine at all. And I had studied biology and chemistry as an undergraduate, and I was the kind of kid, I was a latchkey kid. I grew up, I'd come home and I would turn on PBS and I'd watch Nova and I'd watch the Science Channel that was existing back then, which was like one. And then when I was in high school, I really was attracted to the life sciences, and that was what got me going to do my undergraduate work in biology and chemistry. Once I did that, I actually got into a program in New Mexico doing master's work, looking at an endocrine model for diabetes in rats. And while I was there, I earned my master's degree and was introduced to a set of professors who are at the University of Tennessee, and that's where I ended up moving to do my PhD work. While I was there, I was allowed, or to take medical school classes. So I sat in with medical students and I would hear about their adventures because they would get to do clinical stuff and they get to shadow doctors doing procedures and working in emergency rooms. And so that really fascinated me. And I was like, wow, that'd be kind of cool to do that. When I was growing up, the doctor that took care of me was an osteopath, and he was extremely kind and wizened, and he was older. And when I got to college, another osteopath took over kind of my medical care, and just physicals for sports. And if ever I got sick, he would see me. And I found both of these gentlemen extremely compassionate and worked with me in such a way that was very respectful. And it was stuck in my head. They were so personable and friendly and engaging. So when I was thinking about transitioning into medical school, I looked at the program that I was in at the University of Tennessee, and then I reached out to a colleague of mine who was in his just starting his third year at the University of New England. Somebody I had gone to school with when I was an undergrad, and he loved the program. It was positioned on the coast of Maine. It was a beautiful campus, very small classroom. And I reached out to them, had some conversations, and they offered me a seat there at their school starting the following year. And that's when I made the transition to go into medicine. While I was there, I was very active in a wide variety of things and eventually became a fellow in the anatomy and neuromuscular medicine department under the tutelage of Dr. Boozer and others. And these people really helped sculpt me in becoming the clinician I am today. And that required, of course, a year outside of the regular medical school curriculum where I studied anatomy and studied hands-on therapeutics that osteopaths are kind of known for. When I decided to move forward, my goal was to work in a rural setting and kind of the old Marcus Welby concept. So I ended up doing my residency on the West Coast at the University of Nevada. And while I was there, I had the opportunity to do a rotating clerkship outside of the specialty. And the one I picked was in integrative medicine. And while I was there, I ended up spending a month with Michael Gerber, who was an old homeopath and had been doing it for some 20, 23 years and was very savvy with the concepts of integrative medicine, orthomolecular medicine. He even spent time with Dr. Richardson, who was a pretty well-known doc who had been mentored by Linus Pauling. So there was some lineage there, and I was interested because I was never really formally educated on anything that was outside the traditional mainstream medical model. And when I started learning more and more about it, I was really intrigued. And the folks that I worked with there at the clinic were very gracious, very supportive of me and what I was doing. After I finished my residency, I took a job doing emergency medicine in a remote town in Idaho. And while I was there, I had gotten a couple calls regarding a colleague of Dr. Gerber's who was looking to get some heart surgery done. And he needed somebody to come in and sit in his clinic and sort of manage his patients. And what I understood was that he took care of mainly cancer patients. So eventually the phone call came, and I was invited down probably 6 months later to cover the clinic. This gentleman's name was Dr. Douglas Brody, and he was actually James Forsyth's former practice partner. And he was much,
Seriously.
yes,
Oh, what a
he was
connection, huh?
exactly. So he was much older than James was, and he was already in his late 70s when I met him.
Mm.
And I was really impressed by his very personable nature. His bedside manner was, I mean, unquestionably connected with his patients. The thing that got me the most was like when I get down there, I hear these stories of things they're doing with their patients, and I just said, "Jeez, this is like high quackery, right? I'm just like not interested." And so I spent about 6 weeks with them off and on because I was working in emergency room and I was going back to the clinic. And the time I spent with them was really illuminating. Like he would share with me like the role of things like vitamin C,
Mhm.
multivitamins being taken by patients, nutritional status, the role of what you eat, is kind of how you end up doing. And he introduced me to everything from like Laetrile to oxidative therapies. And I had no clue if there was any literature on this. And so I started doing deeper dives. Back then, it was a little harder to pull information off of the
Mhm.
internet. So I ended up going to the library at the university, the medical school there, and looking things up. And he also had a series of papers published in a variety of journals, some very traditional and some, obscure. And I slowly started to piece together some basic knowledge of what his perception was of integrative medicine and certainly integrative oncology at the time.
Mhm.
The thing that moved me the most was the fact that I was starting to see patients with him and without him who were long-term survivors from advanced stage cancers. I mean, cancers that they were diagnosed with in the 70s and 80s, and they're out now 20, 30 years from a state,
Wow.
some with mets to the brain, some with mets to the bone, liver, lung. I mean, disseminated disease that you would think, wow, they would have months to live,
Mm.
and they're alive decades later. So it was a little bit humbling, but I would say that's when I kind of took the red pill and was like, oh, I learned everything I needed to learn in medical school and residency. So I'm going to go spend more time with him. And during that process is when I really started my formal education in integrative oncology.
Mm.
So I was sent to Mexico to work with Dr. Donato Perez Garcia, who developed, insulin potentiated therapy. And
Mhm.
unfortunately, that practice had gotten a bad name because as he was trying to spread the good word about it and how well it worked, a lot of people just said, hey, I think I understand the concept. Let me give it a try. And that led to some people not having great outcomes and having poor experiences with it. So during the years of me practicing fractionated chemotherapy, I've sort of remodeled it and reframed it in a way that could be better understood by our colleagues on the other side who practice traditional oncology, because it falls part and parcel with what they're doing, whether they fractionate their chemo or they give it metronomically, or decide to give it on a different time schedule.
Mhm.
So it's a language that we can both now talk about without spooking one another. So yeah, but that kind of brings me to the point of where I basically had a combined career of doing emergency medicine and doing integrative oncology and integrative functional medicine for about 20 years now. And I've been all over the world. I've spent time with oncologists that did traditional work. In Germany, I spent time with Meredith Rigdon-Lintz, who was an oncologist by training here in the US, who was doing immunophoresis, so basically
Mhm.
filtering the blood of certain known particulate matter that inhibited the immune system from seeing cancer and recognizing going after it. I've had the opportunity to spend time um, also again in Mexico with other providers and even in Asia, got some education through some of the clinicians over there who were doing um, a lot of, I would say, constitutional work. So whether it be hyperthermia, cryotherapy, nutritional fasting, ways of fasting. But little by little, I sort of developed my knowledge base and then ultimately the wisdom to practice those new tools in a way that's um, I think, authentic and integrated so that I can offer the best possible remedies for my patients, but
Mhm.
also not do that in a vacuum or on an island. So I really find myself as sort of a conduit for getting patients not only re-educated about their diagnosis, but also the opportunities for care to include everything. So everything from, traditionally thinking surgery, even radiation therapy, chemotherapy, immunotherapy, targeted therapies, all these things have something to them that give them validity for a specific patient. And then there's reasons not to use some of those
Mhm.
things. And I think ultimately it's recognizing and honoring that patient autonomy comes first. We may not agree with it, we may not resonate with it, but at the end of the day, we had big trials in Nuremberg to say, listen, we cannot experiment and force people to do things that they do not want to do.
I wish we would remember that. Honestly, I wish we would remember that because I think that a lot of people were forced just recently to do things that they didn't want to do because they were fearful of losing their job or they were fearful of not being able to travel again. And so it's not I think we need to go back to remembering the fact that we should not be forced to do anything that we shouldn't do. And this is what happens, Dr. Devlin, that I have found. I've known people that want to try holistic or alternative. It was Dr. Thomas Levy. I don't know if you know Dr. Thomas Levy.
Yeah,
He's really big in ortho. He's going to be at the I Am the Solution Summit.
yeah, he's
But
an amazing gentleman.
he is. He's an amazing guy. He had everybody mesmerized last year when we did it for the first time, the I Am the Solution, a Natural Health Summit. But he himself, I forgot my train of thought here, but he opened my eyes. I remember one time because I always said, I said alternative ways to heal, and I used to say that in my intro all the time. And he said, you know what, Lily, I wonder if you would ever go to an alternative mechanic, or if you would go to an alternative brain surgeon or an alternative, and he made me think, and I'm like, no, it has such a negative connotation. So now I say natural. natural. But here's what happened. You know, when you get a cancer diagnosis, and I hope nobody ever else does, or anyone knows anybody, we could go back to the beginning when cancer was rare in people's lives. But when they get a cancer diagnosis, there's a level of fear mongering that happens that if you don't do something now, and you don't do what is standard and what is conventional, this is what everybody is doing, then you're going to die. That is kind of like the concept. But if somebody goes, and I've coached many women and men who want to do all natural, but then they go, well, my family wants me to go to an oncologist. And I go, okay, if you go to that oncologist, please know these are the tactics that you're going to experience. Maybe you won't, but I'm just saying, just be forewarned. And I would say 9 times out of 10, maybe 9.5 times out of 10, they come back full treatment. You know, they have a treatment plan, crystal ball, you need 40 treatments, you need, all this stuff. And if you don't do it, you will die. And on top of that, the family, the stress of the family saying, you got to do what everybody else is doing or you'll die. So here's the problem: alternative, and then there's conventional. How are you able to, and first of all, you have a piece about you that I absolutely loved from the moment I met you. And how do you get people to see that you can do both, or maybe a little bit of one and more of the other? How do you, as an integrative oncologist, medicine, because you treat more than cancer, you treat the whole body. So how do you speak to your patients or potential clients that are struggling with the bullying that is out there, that you must do one thing or another?
Yeah. I mean, you bring up the really good point. The thing, and I've seen this, of course, myself with my patients, is I have great respect for my peers in medicine, whether they be surgeons, oncologists, radiation oncologists, interventional, cardiologists, interventional radio. All these guys got into medicine for the same purpose, to help, to really provide care at the best level they can.
Mhm.
I've never run into anybody, and I joked about this. We had a think tank last month at these conferences you refer to, and I joked. I said, "There's no oncologist sitting with the radiation oncologist scheming to how they're going to poison and burn some patient. It just doesn't happen."
Mm-mm.
So my concern is that the level of moral injury that physicians suffer, specifically those who care for cancer patients, is so grave and so great that many times, not knowing what the best answer is, they want patients to start doing something, because making no decision is still a decision. And I think that's what their fear is that the patient who's questioning what their plan is, and how the next steps they're going to take, and there is a rush, there is a fear that was placed in them when they were early in training that makes them behave the way they do. And they believe that, the NCCN guidelines are the Bible, that the ASCO and the sub colleges of ASCO all have the best answers based on big data. And they certainly do have some great answers and some phenomenal tools. And we've really changed the game for things like melanoma and even breast cancer these days. We're doing really good work on the traditional side. But the sad part is like, nobody makes the best decisions in a state of fear.
No, you're right.
So to remove that is one of the biggest things that I've strived to do, because I tell my patients, I said, listen, there's two people sitting here in this room. Man, you may outlive me and you're older than me. I have no idea what my destiny is, nor do I know what yours is. So I have no crystal ball. I have no
Mhm.
way to tell you which best decision to make, but I can guide you based on my experience, based on real world data, based on the evidence that exists, both in the integrative realm as well as in the traditional medical realm. So what I do is, I think, open communication, empower them with knowledge and information. And we're doing that every day, whether it be, doing, next generation sequencing on tumors, looking at their own personal genetics to see what they might tolerate or not, pharmacogenomics. I mean, a lot of oncologists don't even do that, but wouldn't it be nice to know if they're not really going to tolerate a medicine,
Mhm.
that you would know that before giving it to them? So I think there's a lot of a preamble that goes into managing a case. And then ultimately, making those referrals. I desire that all my patients visit with their primary doctor to discuss options, to visit their oncologist to discuss options, at least to hear their story, their plan. If radiation is on the table and needs to be discussed, it's best to come from those experts. But I've worked with everybody. I've worked side by side with oncologists, with radiation oncologists, and these folks have a lot to offer. But based on their trauma, their own personal history to get where they are in their careers and what they've seen in their own patient population, they're morally injured. And that's plain and simple. So they are scared for their patients. They're scared, certainly, kind of for themselves, is like, what's going to happen to my patient? I don't want them dying or having complications. So there's a rush to make decisions by two people who are maybe a little more frantic than they should be.
Hmm.
I'll give you an anecdotal story. I
Yeah.
was working in Colorado for a period of time, and I was introduced to a patient and her twin. They both were diagnosed within about 6 weeks of each other having breast cancer. One patient was very holistically minded and didn't want to do anything. She didn't want to do chemo. She didn't want to do radiation. She didn't want to have surgery. She just had the biopsy. And the other patient basically did everything: biopsy, mastectomy, uh, post surgical radiation, as well as chemotherapy and hormone blockade. So her sister that went through this entire therapy, it was a struggle for her. And the other sister who chose simply to change her diet by removing all sugar, all processed food, all sugar. So she basically assumed a ketogenic, maybe a little paleo style diet. And she would see me on occasion just for follow-ups to check the mass and how she was doing. Ultimately, the sister perished in about 11 months that did the chemo and did the radiation, did the surgery. The other sister, at 79, they were diagnosed. The other sister lived till she was 85 years old and
Mm.
passed away from complications from a hospital stay, but not from her cancer. So I don't have an answer. I wish I could. I mean, this one's certainly weighted towards, hey, change your diet, you might be doing something. That's not the message. The message is I don't completely know what's the best way, because I can't always foreshadow what may happen with a patient who gets surgery, who gets radiation, who gets chemo. Our hope is that we're going to navigate all those roads very well and safely, and the outcome would be that the patients do great. The other thing I notice is that everyone tells the terrible tale of their trials and tribulations in the realm of oncology. Very rarely do you hear a patient come forward and say, "Yeah, I had the stage 4 disease 7 years ago, and I cleared it out the first time, and I have no evidence of disease since then, and all I did was the traditional recommended work." So I don't want to either politicize and or ostracize any practice, because I think that there is a best way for each person, and that way needs to be individualized and personalized, and I think we can do that. I had mentioned beforehand, prior to our getting online together, is that
Mm.
we are all heading to the same place, and I call
Mm.
it the open field, the open meadow. But whether you're a traditional oncologist, surgeon, radiation oncologist, integrative practitioner of some sort, patient navigator, our goal is to provide the highest quality, precision-based, personalized integrative oncology that can be offered to these cancer patients. End of discussion. We're all heading to this place, and we're getting there primarily through science, but also the avenues that a lot of us who are more empathic take by really listening and honoring and acknowledging where patients are on their journey. Because sometimes I talk to patients and I say, well, why do you want to live? Is there a purpose? You're in your early 60s, you have now new grandchildren. Talk to me about what motivates you to pursue any form of therapy. Because if the patient isn't bought into doing something for themselves, then that's a hard road to hoe if they're not, you know, truly behind it, because some of the stuff they're going to be asked to do is really heavy lifting. But ultimately, I think our future destiny is going to be in that field, in that meadow. We're all going to meet and go, hey, what the heck are we doing here? We're all on the same page now. But it's coming. That time is coming.
I love your vision and I'll join you in that vision. I agree. I mean, I see people that go through the conventional treatments and they are fine. And there's others that go through that same treatment and they don't make it. I love the story of the two twins that you saw. And I truly believe in the United States, when you're sent home to die, and this is what Dr. James Forsyth, who, by the way, for those of you who haven't met James Forsyth, you can go to my YouTube channel if the classes are still there. But since I was on the radio, I think we have it on the Voice at least. Dr. James Forsyth, stage 4 cancer, sent home to die, 70 to 75% success rate. And I'm like, what? How many of them are, this is on the phone. We were doing the interview on the phone back then when we were doing radio. And but we had to get him back because he kept falling. He kept the call kept dropping, and typical phone radio type thing.
Right.
But finally, when we got him back and he was able to share what he was doing, he took the best of the both worlds and said, if they're not sensitive to chemo, I will do a small amount. I think he said it was 10%, maybe 10 to 20% of the dose of chemo, along with the, insulin potentiation therapy. He was doing that. He was doing poly-MBA. He was doing so many different things to help with that, with the body. And I remember listening to him going, wow, he married the two. He became a holistic oncologist. He was truly an oncologist. That's what he was trained for. But there was something that happened with him, which was he realized that the herbal store in the corner was getting better results than he was getting. So you talk about that moral, that moral looking at yourself and saying, okay, judgment, what am I doing here? And that's what he did. And I love the fact that your vision sees all these different modalities coming together in one green meadow and coming together and figuring out what's best for that particular patient. With that in mind, many times, because of ignorance, let's put the doctor out, but the fear of the patient, because when you hear cancer, you think of every single movie, you think of every single bald head that has lost their hair, lost everything, bone to die. But I've seen both. And so what my conclusion is what you said at the end, which is their will to live. How important is that will to live, and the fact that they haven't reacted to the chemo? How important is it to test the blood or test the body to see if they can do chemo? Do you feel that chemo, given in the traditional sense, 100% is good? Or do you feel that, or in your research, not feelings, your research showed that the chemo at a small dose can behave better in the body that is not sensitive to chemo?
That's a good question. I don't know if I have the exact answer, but I have my experience
Okay.
with seeing these. And I would say chemo that's not tolerated, there's very poor compliance with it, right? So that's one big caveat. So if you get one or two big doses and you're like, I'm not doing this anymore, then it's not effective. It's not going to do what it needs to
Yeah,
do.
I see your point.
Nibble a bit at the cancer, but generally these things are given over months and require time between each dose so that you can recover from it, right? Without needing a bunch of other supportive medicines given to you. On the fractionated side, that was my real first experience besides, being on an oncology ward, traditionally speaking. If they're in the hospital and they're on the oncology ward, they had a rough ride. They had a bad experience with some of that or a complication, generally immune issues, anemia. So those problems are exacerbated and magnified when you're in the hospital looking at cancer patients versus the clinic side. Not all the patients end up in the hospital, right? Some of them, yeah, we did okay. I survived, a little nauseous, whatever. And then they get through the other side and they're alive and well and just sort of in surveillance. With the fractionated chemotherapy side, we give it more often. I believe the mechanisms that I was taught to use do generate as good as results as I've seen with dose dense in solid tumors. I
Mhm.
don't see great results with fractionated chemotherapy in blood-borne cancers, so leukemias and lymphomas. I think those are
Mhm.
better served through a traditional approach with supportive care. That's been my experience. But I've also seen patients who have failed traditional heavy doses, and I've reused some of those medications they had received in a fractionated style, and they again began to respond. And I think that's because of that biologic response modifier we've been using throughout the years that Donato taught us about. I think there's a real there, and I think more exploration through the use of insulin needs to be made in traditional research because we do understand on the cellular level that these cells have, a few more insulin receptors, they have a few more IGF-1 receptors, and insulin tickles both of them. and causes those cells to behave differently. It wakes up sleeping cells, makes them eat. And then the active cells are going to eat a little bit more. They're going to sort of be first at the table, first to feed on things that are in their environment, including chemotherapy. So I would guess to say that it just depends on the individual. In some pathways, it's going to be a dose-dense model. In other pathways, it'll be a fractionated model. But ultimately, it's the best model would be developed, personalized for that patient. And I wouldn't know until I evaluated the patient themselves.
So when you evaluate, do you propose that everybody, and this is what I think, and it's not based on science, only my research on and what I've seen out there. If somebody is sensitive to a particular chemo, should everybody know if they are completely, how many types of chemo are there? Were there like
Oh, there's
four?
hundreds of chemo. Yeah, here, I mean, I've got this book that sits on my counter, and basically it has, and this is from 2020, but this is DaVita and Chu's Cancer Bible. And so in here exists a numerous amount of chemo that you can use, some of it very old school, even based with nitrogen mustard gas, all the way to some new school stuff, which would be your targeted therapies, from tyrosine kinase inhibitors to immunotherapy like checkpoint inhibitors. I think I want to clarify chemo because chemotherapy, most people already instantly think of, oh my God, they're poisoning me. It's, going to mess with, my hair growth, nausea, vomiting, diarrhea. I'm going to have sores in my mouth. My skin's going to slough off. That's a horror show that's been promulgated by folks who maybe have something to gain from people being scared of chemo. And I
Oh,
want to make sure that
wow.
story is fairly told because there are some rough chemos out there and there are some things that you don't want to have happen to you that can be complications of getting chemotherapy, but not all of the tales of woe are hitting everybody. So when chemo is given in a thoughtful manner, and I'll be honest, it gets really technical, but at the end of the day, I'm not going to mention them, there are labs that exist in this world that claim to be able to determine exact chemosensitivity for a given cancer and a given patient's cancer for that matter. My experience has been both good, bad, and ugly dealing with these
Oh,
lab
so
entities.
they're not conclusive. They're not,
But that you when the always the as somebody who's trained in statistics, I'm a big fan of specificity and sensitivity. Like, am I getting the results that I need and are they appropriate? Some of the big questions I ask are what happens to cells that I remove from the body and expose to real world environments, whether it be radiation, temperature changes, pH changes, and then all of a sudden it ends up in a foreign space and it's put into a test tube or it's put into a jar or
Mhm.
a petri dish, and all of a sudden I'm exposing it to different things. Do you believe that that cell's the same cell that came out of the body, behaving exactly the same way? Based on my experience doing cellular biology and growing cells up in medium, I'm challenged to say that it's exactly the same cell because I don't believe
Mhm.
it is. I believe it's undergone some changes. So how can I translate this new cell, this stress cell's response to a variety of pressures from, different chemos or supplements, and how am I going to apply that to my patient? And is that going to be a direct application that makes sense?
Interesting.
Unfortunately, that's what originally caused me to question some of these labs is because I was seeing patients not do as well based on recommended changes. So I had to go back and sort of test the lab. And in doing so, I elucidated that the sensitivity and specificity wasn't where I needed it to be. So I've reverted back to using other testing models. There is a brand new company that came out of the Middle East as well as Europe that is now doing some similar testing. And I just started to be experienced with them over the past year. And I'm still yet to have any conclusions. A lot of times, recommendations that are made by these companies also correlate with what big data shares with us about the use of either repurposed drugs, supplements, chemotherapy, and most of the chemotherapies they recommend usually fall within the NCCN guidelines of drugs to use for a specific cancer. So I take some of that stuff with a grain of salt. The stuff that I'm really impressed with are the labs doing next generation sequencing, and there's some wonderful labs out there doing it, looking literally for the genes that are responsible for the tools that these cancer cells apply in their environment, either to promote growth or the breaking mechanism. So whatever genes are normally used for breaking cancer growth, if they're defective and non-wild type or mutants, then how do we get around that? Are there tools available? And literally, you're talking about hundreds of labs, if not thousands, across this globe
Mm.
that are working to target these specific genes in their downstream products. And that's where that personalized, precision-based oncology comes into play. Because when these tests are regularly done over and over and over again with our patients and in a timely manner, we literally can pivot and we go for 2, 3 months, resample. Okay, this is now sensitive to this drug and no longer sensitive to this one. Let's pivot. So we're going to be able to create a pathway based on these markers that we'll check in with, whether it be circulating tumor cell
Mhm.
DNA,
Mhm.
circulating tumor cells, or gross tissue specimens taken through biopsy. But literally, we then could find that path out of the disease for the patient.
Very good. And so you're saying, what I'm hearing you say is that there are tools that may be better, and you're still, the verdict is still out, and how good they are, the company from Israel or the Middle East. And then you're also saying that there are other ways to test and have a little bit more conclusiveness of whether this is going to be the best thing for them or not, but still trying it on them is probably going to be the most revealing of the sensitivities and how they
Yeah,
respond to it, right?
absolutely. Yep,
So
dead
do
on.
you,
And that's
when you're doing that, do you start small? Do you start small, or do you give
yeah,
the
it depends. You're asking a good question. It depends on the mechanism of action of the drug. If the drug works intracellularly, right, and has to be taken up by the cell to have its negative effect, then you can use some of the mechanics behind the FCBRM model, which is the fractionated chemotherapy model. But if it's an external receptor or something that you want to modulate as far as, maybe neoangiogenesis, or how a cell is communicating with another cell, then you can use other tools,
yeah.
but they would have to be generally at doses tolerable by the patient. Some of these targeted therapies, they start at a high dose and then they'll taper down if there's side effects. The other
Mm.
philosophy is starting at a low dose and working up till they see a side effect and then they back off to the tolerated
I
dose.
like that. I like
Yeah,
that
that, well,
better.
that seems to make more sense. Uh, Drugs don't work if there's no compliance with the medication, right? So I'm always about making the patient as comfortable as possible with whatever regimen they're following so they're compliant with it. Most patients don't want to come and tell me like, hey, I can't do any of this stuff because it causes X, Y, and Z. So I want to meet them honestly where they're at. And some patients are like, doc, I'm not doing that. I just can't. And I'm like, okay, well, let's see if there's another substitute or another way we can address the issue. So, and we just have to be flexible and work with the patient, because there's so many patients I've seen, unfortunately, just want to be, yes, 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 I did exactly what you said, and then they don't, and then they have a bad outcome, and that's the last thing I want.
Well, it's wonderful to hear that you're so communicative with your patients. Now, in your clinic, because well, let me just take a little break before I talk about your clinic and some of the ways that people can get a hold of you if they wanted to ask questions and all that. But I do want to talk about for those of you who understand that there are so many different ways to help the body heal. And I wanted to bring this conversation today about integrative oncology because there's not a lot of people talking about it. And I want to make sure that all of us have all the information, not one side or the other, both. And I really do believe that in certain cases, both may be what you need. In other situations, like the twin that Dr. Devlin was talking about, change their lifestyle, change. I would think that that would be the first thing anybody would want to do before moving forward to doing something a little bit more dramatic. However, everybody needs to make their own decision. And so if you are ready to take your health back, and as opposed to giving your power away and being scared into deciding what to do, if you're ready to take your power back, go to whenyouneedafriend.com. This is where we take 100% ownership for our life. The registered service mark is you can take a pill, take responsibility. It's not that I'm against the pill, is that I'm for you doing everything you possibly can to live the life that you want. And so sometimes we have these little trials in life or big trials in life that teach us how resourceful and resilient and that we truly are. And so if you're ready to take your life back, please, when you go to whenyouneedafriend.com, please subscribe, like, and follow me on all social media. For those of you who are subscribers, you already have Dr. Devlin's information, and you're able to click on his name and it'll take you to the Gerber Clinic or the gerbermedical.com. That's where it will take you. So please subscribe, and please go check out my sponsors, support them the way they're supporting the classroom. Check out my Shop Now bag. Some of those are affiliate products, some of them are not. I just want you to know what works for me may not work for you, but give it a try, because I look at everything that's natural and holistic first before trying something totally different. And then there's the event that we're doing on April 6th, the I Am the Solution Natural Health Summit. I am giving 2 tickets away, 2 tickets away. So let's see, today, so you have today, tomorrow. So we'll do it tomorrow. I will draw two names, and text me at 407-373-5959 and let me know that you would like to attend the I Am the Solution Natural Health Summit, and that is on April 6th, 2024. The registration table opens at 7:30 in the morning, and we will be done at 6 p.m. We'll be done. And all of us it is a wonderful experience where you go with like-minded people and you get to share and people listen and you get to learn new truths. So please consider joining us. But you can enter, if you text me that you want a free ticket, you'll get two, so that you can come with somebody that you love. Just text me at 407-373-5959. If you want to get your ticket, you can enter Lily 001 as you get $24 off your price of admission. So check it out. And when you go to whenyouneedafriend.com, it'll pop up. So go there. Last but not least, you can become an enrolled student in the classroom. So whether it's $1 or $1,000 a month, whatever you can donate to help the classroom grow, we are so grateful. Whether it's your time, your talent, your treasure. Heck, just sharing this video today is helping the classroom grow, because the algorithms, they are making sure that this information doesn't get out. We want to have these conversations, loving conversation. You know, in Hosea 4:6, it says, "My people perish for lack of knowledge." And it's not that they didn't have the information. It's that they rejected the information. That is the part of Hosea that nobody reads. But that's the part that we need to understand. You've been told this information. Now, what are you going to do about it? Well, we're free to choose. And I love what Dr. Sean Devlin is doing. And he is sharing information that for some of us, we're going, no, I want to do this. And for somebody else, yeah, that's exactly what I want to do. So use your own decision-making ability. I think we all have that insightfulness inside of us. And so if you want to learn more about Dr. Devlin, you can go to gerbermedical.com. That's gerbermedical.com. Again, just click on his name in the blog and you will have his information. Dr. Devlin, I am so grateful to you. And I love this conversation that we're having because, as you know, I tend to be more natural and holistic. But are there particular cancers that are better done, like the twins that had identical cancers and one chose to change their lifestyle versus the other one who went the full traditional route of chemotherapy? Do you find that there are particular cancers that do best if you try to change your lifestyle first?
That's a really good question. But I'll be honest with you, when we look in general at sort of the statistics around cancer, they say somewhere around, 15-20% of all cancers, there's some genetic tie-in, right? There's some genetic potential driver that's helped create this. And then there's this thing they call the epigenetic phenomenon, right? These epigenetic pressures. Most likely, if you develop cancer, that there's probably something in your lifestyle that may have contributed to you developing the cancer. And it could be a combination of both the background genetics as well as the epigenetic pressures. The classic examples are, you know, obesity, taking in too much sugar, right? Smoking, exposure to secondhand smoke, alcohol. We know that all these things have a negative influence on us. And one of the big things that we hardly ever talk about, is stress, right? Just being under the gun to do something, right? So whether it's workplace stress, at home stress, drama or conflict that is imaginary, I mean, a lot of people will make mountains out of molehills, and that's to their detriment. I mean, our body is built to thrive and survive with some pretty primitive tools. And when you're constantly pushing on your adrenal glands and you're constantly having these imaginary, fearful events happen to you, whether it be, financial distress, of, alienation of affection, lack of connection, all those things play a role in creating the environment that is you. And so at the end of the day, to remove those negative influences and bring on positive ones that are about building you up and supporting you, and also taking your brain back a little bit from being such an overthinker. So, and making it something that you can do on a daily basis, I think is really critical. So changing your lifestyle is generally a must. I mean, I kind of take that as sort of a no-brainer, but it's a conversation that most of my patients will have throughout the, introductory meetup with me. And a lot of things that, because they want to know why. Like, why did I get cancer? I mean, like, I'm a triathlete. And then you come to find out they're on their fourth marriage, right? And that they were abused as a child. And then you start to go, okay, well, those things don't really help you, to get to where you are now, even though you're living in maybe a physically healthy lifestyle. But do you think if I eat a lot of pasta, that can be bad? Well, yeah. So we do deeper dives on patients' sort of functional background, like, hey, are they insulin resistant? Are they insulin, sensitive? Have they lost that? Majority of people by the time they're in their 50s and 60s are all pre-diabetic. They're all usually, got fatty organs, they got a little fat around their liver. These are real problems that as we go through life, they just bioaccumulate, same thing with
Mhm.
toxins and, chronic infections. I mean, a lot of people have to put those into perspective, just because you got Epstein-Barr doesn't mean you're guaranteed to have some form of lymphoma, right? But is there a potential corollary? Yeah. And so we have to keep looking what possibly could have either monkeyed with my genes or put pressure on my survival systems. And some of those are simple biochemical things like, hey, there was a mistake made in replication of DNA. Let's repair it. Well, now that repair mechanism is broken, so that little biochemical mechanic can't show up and do his job.
Mhm.
So you're bringing up some really important things because if you don't change those basic issues, you're going to still deal with that sort of poison background that had possibly brought this disease to the forefront in the first place.
I love that connection that you made, and I don't know if that was a real situation with the running, the triathlete, but 4 marriages, and I don't know if that was even a real scenario, 4 marriages and abused as a child. I find when I'm working with people, I'm not saying all runners that has happened to runners, but usually there's something that people are running from. It is amazing how our bodies are doing the things that we need to really. I don't know if it's just the fear of not wanting to face it. And I'm not saying that everybody who runs is running away from things, but when they're running and there's a diagnosis, there's usually something they're running from. I don't know if you found that with speaking to your patients, but I find that with me as well.
Yeah, I mean, running is a tool for sure, and some of it's literal, like they are trying to flee from some situation or
Hmm.
stressor, and the other one is sort of this figurative thing that they use to say by running it brings them peace of mind. It
Hmm.
elevates enkephalin and endorphins, and
Yeah.
the runner's high is a real phenomenon. So when you've experienced it, you'll get back on the road and go out for it again. So, and I think that those are just reflections of why people do the things they do. Because
Yeah.
I've taken care of runners who are like, in their 40s and they're looking at new knees or new hips, and they've run their body system pretty ragged. Over exercise, everyone says, oh, exercise is great for cancer. Over exercise can be a hazard to cancer
Hmm.
patients, and it should be patient appropriate. I'm not going to have the 62-year-old lady who's got metastatic lumbar disease squatting. She's not deadlifting and squatting, right? She may want to go to the gym, use some bands, do some movement, get in a pool, swim around, but you've got to be really appropriate as to how you manage some of these things. And I can't have my already thin patient, well, I'm doing the fasting. Walter Longo says I should fast before chemo. I'm 89 pounds and 5'5". I'm like, no, fasting is not really appropriate for you right now. So everything has to be really patient specific, and that's why
Mhm.
when people ask blanket questions, I'm like, it depends. Um,
Let's dig a little bit more. You should have a shovel in your office so you can start digging, a soul shovel so you can
Absolutely.
get to the truth so as you are looking at each patient, how much time, first of all, I just need to ask, does Gerber Clinic, Gerber Medical accept any insurance?
They do not, yeah, because we
Okay.
do have a very low patient volume, so we end up seeing patients for an hour and a half to 2 hours or more at a time, and the insurance model would not be conducive to us keeping our doors open.
And that is so sad. This is what I'm saying. We're being manipulative in so many different ways without us knowing whether it's fear or they're not going to pay for my treatment, and then we end up doing what they want because it's a form of manipulation. I love the idea, just do whatever you can naturally, depending on the situation, but also have somebody that can coach you and co-partner with you to make the best decisions for you. So that's there. So I wanted to ask about the insurance because that seems to be a manipulator for some people. That's well, I've got to go where my insurance. But let's talk about the out-of-pocket expenses here. When people are using insurance versus paying cash for where they want to go, is that out-of-pocket expense different than the out-of-pocket expense when you go the conventional or through the insurance route? What
Yeah,
have
so
you seen?
Yeah, so in general, it ranges. So some people have phenomenal insurance with very small deductibles, and those people basically pay little, a small percentage, maybe 2 to 5% of the total costs, right? It depends. I mean, if you have cancer, I mean, some of the estimates now, a year's worth of therapy could approximate $400,000, right?
Yeah, but
So
2% of that is a lot of money,
it
right?
is a lot
And that's not even including medications too.
for
So
sure.
yeah.
My take always has been, and I've advocated for this since I really started doing it, because one of the rate limiting steps for patients is the fiscal component. Certainly, time is of a concern, being away from work, but ultimately, getting a third party advocate involved. So, a third party biller, a coder, somebody that can really take some of the components of the bill itself to try to get reimbursement for these patients. Nobody gets insurance not to have the kind of care they want, but when they're faced with getting care and they realize, I want some other options, and they find out it's not part of the menu, then that becomes very frustrating. And I have this conversation every day with patients. And so we try to minimize the financial impact. But since COVID, I'll be honest, a lot of the cost of goods sold in these integrative centers have gone up. And even getting some of our repurposed medicines has been a big challenge.
Mm, yeah, it's a sad thing. It's a sad
Yeah.
thing. So how do people start the process with you? Do they reach out? Do they go to info@Gerber?
Yeah, they
Um,
can go there. They usually call one of my staff. So Inga Gerber is Dr. Michael Gerber's wife, or they
mhm,
talk to his son. We have a couple other employees there that are on the clinical side, but basically just reaching the front desk starts the process. I ask for a variety of things. So there's a template that gets sent out to the patient,
mhm,
and they're asked for recent labs, imaging, original path reports, oncologist notes if they have any, also any records around their general health. So PCP, their primary care doctor, may generate a note. But ultimately, it's gathering all that data along with a little history, including sort of the psychosocial, emotional history stuff that would come along with anybody who's doing a deeper dive.
mhm.
And then we look at what supplements they're on, what medications they're on, what they're tolerating. But it's like a little narrative they'll share with us along with some of that objective data. And then I take, an hour or two to go through all those records, and then we get them on the books in a timely manner. If I can see them, if they're remote, then I'll start to actually investigate because I get people from Europe and, other countries that want
So
to
you
come.
so you
So I
do
seek out
telemedicine?
places near
Can you
them.
do telemedicine for your first
I can, yeah,
consult?
yeah, I can do
Okay.
telemedicine,
Yeah.
but I'll be honest with you, a lot of the benefit comes not only from the information I share, but from the wet work provided. So whether it's
Mhm.
recommendations for, orthomolecular tools or chemotherapy or immunotherapy, I need to make sure that there's a place near them that they can access, because it's not them just coming to see me. That's one thing, but a lot of people can't afford to come and spend weeks, months, or longer seeing somebody to care for their disease. So I want to be cognizant of that.
Yeah. Absolutely. And I noticed that you treat other things. You have other, if you go to gerbilmedical.com, you'll see all the services that they have. I know we're getting closer to the end here, and I know that this is not going to be this is going to be the first of many conversations with Dr. Devlin, because I really do appreciate what you do and the peace that you bring in such a chaotic time in people's life, and so I'm very grateful to you for that. But I also know that you help with other diseases, not just cancer. So can you share real quickly, what are some of the other conditions people can come to you for?
Yeah, in general, I'll treat kind of, what they call CFIDs or ME/CFS, which is, used to be called like Lyme disease, Lyme and the co-infections. I did some training with infectious disease guys. I also did some training with ILADS, which is well known sort of in the integrative infectious disease community. But really, at the end of the day, I'll take on any patient with any problem. Ultimately, my goal is to give them at least some insight of other avenues they can take to get better. The big thing for me is to make it as personalized as possible and keep it so that their autonomy is always respected and kept, in the front of my mind. But ultimately, I may not be a good match for some patients, and those patients, I want to get them in front of some of my colleagues who better reflect their needs. Because no matter what I'm treating, whether it's chronic pain or chronic infections, or somebody's there just for age management or hormone replacement, or trying to deal with a workplace injury, or could be really anything. I want to make sure they get the best of care. So usually I'm in charge of putting together a team of people that can assist them to get down the road to where they want to go.
Well, I tell you what, I'm looking forward to our next conversation already, because you've shared some pearls, that I'm going to sit with for a while, because, I'm I will say I'm very vocal about natural health, very vocal. And but I also have seen the benefits of insulin potentiation therapy. I've heard about it through Dr. James Forsyth, but I also love the fact that you add a different component, which is that specialized, that you look at the individual and start small and work bigger, as opposed to starting from the top and working low. So what is your advice for someone that has just received a cancer diagnosis and is overwhelmed at this time in their life?
Yeah, first thing, don't panic. The big C actually in 2024 is just a C. It's a regular size C, and I want people to take it seriously, but I don't want their monkey mind to take them down a dark and desperate road, because we have so many solutions and so many therapeutics out there now that can be very helpful when used appropriately. But even better is what's coming out in the next 6 months, 12 months, 24 months. If you're alive in 2 years, your options for care are going to be growing by leaps and bounds. And I'll tell you what's very exciting is now AI has been unleashed on this new sort of drug finding mission. And what we're seeing is a lot of real positive data coming out on the biochemical side, suggesting that we're going to have even more tools at a faster rate of speed for helping patients as individuals with precision-based therapeutics. So tell them, don't panic, take a deep breath, love themselves, and start working with folks like us.
You know what? This is the first time I've heard the word AI, the initials AI, that got me actually excited. I mean, I am very fearful of AI. I'm like, oh my gosh, anybody could say anything about anyone. But to see that it could be used as a great tool to help, pinpoint what works for somebody, that I'm open to learning more about that. So
Yeah.
keep doing that research. I know that you're a huge researcher, and I am so grateful for you. And what I love about you is that you present both facts, both sides just as lovingly. And I can tell that you just want what's best for the patient. And so that's why you're able to say there's no doctor out there that wouldn't want this for the patient, because that's how you're looking at yourself through all these other doctors. So I thank you for that. I thank you for bringing hope as well. So thank you. Is there anything last minute that you would like to say before we go?
No, you've been phenomenal. Thank you so much for bringing me on the show.
Oh, thank you. And please remember, you will be right here waiting for you worldwide at whenyouneedafriend.com. This is Lillian McDermott and Sean T. Devlin, Dr. Sean D. Devlin, wishing you love, peace, joy, and unexpected abundance. Make it the best day ever. Good job. Good job.
The opinions and advice expressed on the Lillian McDermott radio show are intended for the individual callers and guests on the program and are presented to our wider audience solely for general educational purposes. Please act responsibly and consult personally with your own medical, psychological, or nutritional expert before